Question 1. A 50-year-old male presents with sudden onset of severe chest pain and shortness of breath. His ECG shows ST segment elevation in leads V2, V4. What initial action should be prioritized for this patient? A. Administer intravenous adenosine. B. Prepare for immediate cardioversion. C. Activate the cardiac catheterization lab. D. Obtain a full 12-lead ECG and repeat vital signs. Answer: C. Activate the cardiac catheterization lab. This question tests your understanding of initial management for ST elevation myocardial infarction, STEMI, signaled by the severe chest pain, shortness of breath, and ST segment elevation on the ECG. The most critical action for STEMI is timely reperfusion, which means opening the blocked coronary artery as quickly as possible. Activating the cardiac catheterization lab for percutaneous coronary intervention, PCI, is the preferred reperfusion strategy, aiming for a door-to-balloon time of 90 minutes or less. While obtaining a full ECG is important, immediate activation of the cath lab takes precedence once STEMI is confirmed. Remember, time is muscle in STEMI, so rapid reperfusion is key. Question 2. During a cardiac arrest, a patient is in ventricular fibrillation, VF. After the first defibrillation attempt and 2 minutes of CPR, what is the next appropriate step? A. Administer 1 mg intravenous/intraosseous for /IO epinephrine. B. Administer 300 mg intravenous/intraosseous for /IO amiodarone. C. Check for a pulse and rhythm. D. Administer 1 mg intravenous/intraosseous for /IO atropine. Answer: A. Administer 1 mg intravenous/intraosseous for /IO epinephrine. This question focuses on the ACLS cardiac arrest algorithm for shockable rhythms. For ventricular fibrillation, after the first shock and 2 minutes of CPR, the next step is to administer a vasopressor like epinephrine. Epinephrine helps improve coronary and cerebral perfusion during CPR and increases the likelihood of successful defibrillation. Amiodarone would be considered after a second shock, and checking for a pulse/rhythm only occurs after a 2-minute CPR cycle or if rhythm changes, not immediately after CPR following the first shock. Always remember that epinephrine is given during ongoing CPR in the shockable rhythm pathway after the initial shock. Question 3. What is the recommended dose of adenosine for the initial dose in stable monomorphic ventricular tachycardia with a pulse if vagal maneuvers are unsuccessful? A. 3 mg rapid 4 push. B. 6 mg rapid 4 push. C. 12 mg rapid 4 push. D. 1 mg slow 4 push. Answer: B. 6 mg rapid 4 push. This question evaluates your knowledge of specific drug dosages for stable tachyarrhythmias. For stable narrow complex tachycardias or potentially stable monomorphic ventricular tachycardia, adenosine is the first-line medication, given as a rapid 4 push followed by a flush. The initial recommended dose of adenosine is 6 mg. If the rhythm does not convert, a second dose of 12 mg may be given. Always administer adenosine as quickly as possible, followed immediately by a saline flush, to ensure it reaches the heart effectively before it is metabolized. Question 4. A patient in cardiac arrest has achieved return of spontaneous circulation, ROSC. Which of the following is an immediate post-cardiac arrest intervention? A. Target temperature management, TTM. B. Perform a neurological exam. C. Optimize ventilation and oxygenation. D. Administer prophylactic antibiotics. Answer: C. Optimize ventilation and oxygenation. This question tests your understanding of the immediate priorities following return of spontaneous circulation, ROSC. Once ROSC is achieved, the primary focus shifts to optimizing ventilation and oxygenation, along with maintaining adequate blood pressure and identifying the underlying cause of the arrest. Target temperature management, TTM, is crucial but is typically initiated after these immediate stabilization efforts, once the patient is hemodynamically stable. Ensuring effective breathing and adequate oxygen levels are foundational steps to prevent rearrest and protect organ function. Always focus on the ABCs, airway, breathing, circulation, immediately after ROSC. Question 5. During a resuscitation attempt, the team leader asks for synchronized cardioversion. The patient is awake but hypotensive with a wide complex tachycardia. What is the most appropriate next step? A. Administer intravenous amiodarone. B. Administer intravenous adenosine. C. Deliver unsynchronized defibrillation. D. Administer immediate synchronized cardioversion with sedation if possible. Answer: D. Administer immediate synchronized cardioversion with sedation if possible. This question assesses your response to unstable tachycardia, which is indicated by hypotension with a wide complex tachycardia even if the patient is awake. Unstable tachycardia, regardless of the QRS width, requires immediate synchronized cardioversion. While sedation is preferred for patient comfort, it should not delay life-saving cardioversion if the patient is unstable. Administering medications like amiodarone or adenosine can delay definitive treatment and are generally reserved for stable tachycardias. Remember, if the patient is unstable, hypotension, altered mental status, signs of shock, ischemic chest discomfort, acute heart failure, and has a tachycardia, cardioversion is the immediate treatment. Question 6. What is the primary reason for administering atropine in bradycardia? A. To decrease myocardial oxygen demand. B. To block vagal stimulation and increase heart rate. C. To convert ventricular fibrillation. D. To increase systemic vascular resistance. Answer: B. To block vagal stimulation and increase heart rate. This question focuses on the mechanism of action for atropine in the context of bradycardia. Atropine is an anticholinergic drug, meaning it blocks the action of the vagus nerve on the heart. Vagal stimulation slows the heart rate, so blocking it with atropine helps to increase the heart rate and improve atrioventricular (AV) conduction. It is not used to treat ventricular fibrillation or to increase systemic vascular resistance, and its primary effect is not to decrease myocardial oxygen demand. If a patient has symptomatic bradycardia, atropine is the first-line medication to try and increase their heart rate. Question 7. What is the recommended chest compression rate for adult CPR? A. 60 to 80 compressions per minute. B. 80 to 100 compressions per minute. C. 100 to 120 compressions per minute. D. 120 to 140 compressions per minute. Answer: C. 100 to 120 compressions per minute. This question tests your fundamental knowledge of high-quality CPR components. For adults, the recommended chest compression rate is between 100 and 120 compressions per minute. This rate ensures adequate blood flow to vital organs during cardiac arrest. Compressing too slowly or too quickly can reduce the effectiveness of CPR. Always strive for compressions that are fast enough but not excessively fast, ensuring proper depth and full chest recoil. Question 8. A patient is unresponsive, pulseless, and the monitor shows organized electrical activity but no palpable pulse. What is this rhythm called? A. Ventricular fibrillation, VF. B. Asystole. C. Pulseless electrical activity, PEA. D. Torsades de points. Answer, C. Pulseless electrical activity, PEA. This question defines a critical cardiac arrest rhythm. Pulseless electrical activity, PEA, is characterized by organized electrical activity on the ECG monitor, but with no detectable pulse. This indicates that the heart is trying to beat electrically, but it is not generating enough mechanical force to produce a pulse or adequate blood flow. Ventricular fibrillation and asystole are distinct cardiac arrest rhythms, while torsades de points is a specific type of polymorphic ventricular tachycardia. When you see electrical activity but no pulse, think PEA and the H's and T's. Question 9. What is the initial energy dose for unsynchronized cardioversion, defibrillation, for ventricular fibrillation, VF, using a biphasic defibrillator? A. 50 to 100 joules. B. 120 to 200 joules. C. 200 to 300 joules. D. 360 joules. Answer, B. 120 to 200 joules. This question assesses your knowledge of appropriate defibrillation energy settings. For adult ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, using a biphasic defibrillator, the recommended initial energy dose is typically between 120 to 200 joules, with the specific setting often determined by the device manufacturer. If the initial shock is unsuccessful, subsequent shock should be at an equal or higher dose. Monophasic defibrillators, in contrast, always start at 360 joules. Always know your device and its recommended settings for initial defibrillation. Question 10. Which medication is contraindicated in a patient with suspected right ventricular infarction and inferior ST segment elevation on ECG? A. Aspirin. B. Morphine. C. Nitroglycerin. D. Oxygen. Answer, C. Nitroglycerin. This question highlights a crucial contraindication in the management of myocardial infarction. In patients with suspected right ventricular infarction, indicated by inferior ST segment elevation, leads to 3 AVF, and especially R-sided ECG changes, nitroglycerin is contraindicated because it causes vasodilation and can severely drop preload. Right ventricular infarction makes the heart highly dependent on preload to maintain cardiac output, and reducing it with nitroglycerin can lead to profound hypotension and shock. Aspirin, morphine, and oxygen are generally appropriate in acute coronary syndromes unless specific contraindications exist. Always be cautious with nitroglycerin in patients presenting with inferior STEMI until a right-sided ECG rules out RV involvement. Question 11. What is the most common cause of cardiac arrest in pediatric patients? A. Primary cardiac rhythm disturbance. B. Traumatic injury. C. Respiratory arrest. D. Sudden infant death syndrome, SIDS. Answer, C. Respiratory arrest. This question tests a key difference between adult and pediatric cardiac arrest. In most adult cardiac arrests, the primary cause is a sudden cardiac event, like VF. However, in pediatric patients, cardiac arrest is most commonly secondary to progressive respiratory failure or shock, which then leads to bradycardia and eventually asystole. This emphasizes the importance of early recognition and intervention for respiratory distress and shock in children. Focusing on airway and breathing is often the most critical initial step in a pediatric emergency. Question 12. A patient presents with symptomatic bradycardia, heart rate 40 bpm, and hypotension. Despite atropine, the heart rate remains low and the patient's condition is worsening. What is the next most appropriate intervention? A. Administer intravenous lidocaine. B. Prepare for transcutaneous pacing, TCP. C. Administer intravenous amiodarone. D. Perform immediate synchronized cardioversion. Answer: B. Prepare for transcutaneous pacing, TCP. This question assesses the management of symptomatic bradycardia that is refractory to atropine. If symptomatic bradycardia persists despite adequate doses of atropine, the next step is to initiate transcutaneous pacing. This provides an external electrical impulse to stimulate the heart to beat at a faster rate. Lidocaine and amiodarone are antiarrhythmics, not treatments for bradycardia. Synchronized cardioversion is used for symptomatic tachycardias, not bradycardias. Remember, for unstable bradycardia, the sequence is typically atropine, then pacing, dopamine, or epinephrine infusion, and possibly transvenous pacing. Question 13. What is the recommended depth of chest compressions for an adult during CPR? A. At least 1 inch 2.5 centimeters. B. At least 2 inches 5 centimeters. C. At least 3 inches 7.5 centimeters. D. No more than 1.5 inches 3.8 centimeters. Answer: B. At least 2 inches 5 centimeters. This question emphasizes another crucial component of high-quality CPR. For an adult, chest compressions should be at least 2 inches 5 centimeters deep but no more than 2.4 inches 6 centimeters. Compressions that are too shallow are ineffective at circulating blood, while excessively deep compressions can cause injury. Proper depth is essential for creating adequate blood flow to the brain and heart during cardiac arrest. Aim for consistent, deep compressions with full chest recoil. Question 14. A patient in cardiac arrest is receiving CPR. The capnography waveform shows a sudden sustained increase in end-tidal CO2, EtCO2, from 15 mm of mercury to 40 mm of mercury. What does this likely indicate? A. Inadequate chest compressions. B. Esophageal intubation. C. Return of spontaneous circulation, ROSC. D. Metabolic acidosis. Answer: C. Return of spontaneous circulation, ROSC. This question tests your ability to interpret capnography findings during resuscitation. A sudden, sustained increase in end-tidal CO2, EtCO2, during cardiac arrest, especially a rise to 35 to 45 mm of mercury, is a strong indicator of return of spontaneous circulation, ROSC. This increase reflects improved pulmonary blood flow as the heart begins to pump effectively again, allowing more CO2 to be delivered to the lungs for exhalation. Inadequate compressions would likely cause low EtCO2, esophageal intubation would cause a flat or very low EtCO2, and metabolic acidosis typically doesn't cause a sudden increase to normal values. Always look for this critical capnography clue during resuscitation. Question 15. What is the maximum recommended number of uninterrupted minutes for a single cycle of chest compressions before assessing the rhythm or pulse during CPR? A. 1 minute. B. 2 minutes. C. 3 minutes. D. 5 minutes. Answer: B. 2 minutes. This question relates to the importance of minimizing interruptions in CPR. High-quality CPR emphasizes cycles of 2 minutes of continuous compressions before pausing briefly to assess the rhythm and pulse, if indicated. Limiting pauses to less than 10 seconds is crucial for maximizing coronary and cerebral perfusion. Interruptions longer than this can significantly reduce the effectiveness of CPR. Always aim for consistent, uninterrupted compressions for 2-minute intervals. Question 16. A patient presents with acute onset of severe chest pain and diaphoresis. Their blood pressure is 80/50 mmHg, heart rate 110 bpm, and respiratory rate 22 bpm. ECG shows wide complex tachycardia. What is the priority intervention? A. Administer intravenous amiodarone. B. Administer intravenous lidocaine. C. Prepare for immediate synchronized cardioversion. D. Obtain serial 12-lead ECGs. Answer: C. Prepare for immediate synchronized cardioversion. This question describes an unstable wide complex tachycardia. The key clue here is the patient's instability, indicated by severe chest pain and hypotension, blood pressure 80/50 mmHg. Any tachycardia, wide or narrow, that results in signs of instability such as hypotension, altered mental status, signs of shock, acute heart failure, or ischemic chest pain, requires immediate synchronized cardioversion. Medications like amiodarone or lidocaine are for stable wide complex tachycardias or after cardioversion. Obtaining serial ECGs is important but secondary to immediate stabilization. When a patient is unstable due to a fast heart rhythm, shock them is the immediate priority. Question 17. Which of the following is the most appropriate dose of amiodarone for a patient in pulseless ventricular tachycardia, private, or ventricular fibrillation, VF, refractory to initial defibrillation and epinephrine? A. 150 mg 4/IO. B. 300 mg 4/IO. C. 1 mg 4/IO. D. 0.5 mg 4/IO. Answer: B. 300 mg 4/IO. This question tests your knowledge of specific drug dosages in cardiac arrest. For pulseless ventricular tachycardia, private, or ventricular fibrillation, VF, that persists after initial defibrillation and epinephrine, amiodarone is the recommended antiarrhythmic. The initial dose for cardiac arrest is 300 mg 4/IO. A second dose of 150 mg 4/IO may be given if the rhythm persists. Epinephrine is given as 1 mg, and the other options are incorrect for this scenario. Remember that amiodarone is a key antiarrhythmic used after epinephrine in shockable rhythms. Question 18. What is the initial management for a patient presenting with symptomatic sinus bradycardia without signs of hemodynamic instability? A. Transcutaneous pacing. B. Atropine 0.5 mg 4. C. Dopamine infusion. D. Observe closely and monitor. Answer: D. Observe closely and monitor. This question highlights the initial approach to symptomatic bradycardia when the patient is still stable. If a patient has symptomatic bradycardia but is not experiencing signs of hemodynamic instability, e.g., hypotension, altered mental status, acute heart failure, the initial management is to observe closely and prepare for potential intervention. Atropine, pacing, or infusions are reserved for unstable symptomatic bradycardia. It's crucial to differentiate between symptomatic but stable versus unstable bradycardia. Always ensure the patient is truly symptomatic before intervening, but if they are stable, watchful waiting is appropriate. Question 19. What is the primary purpose of early defibrillation in sudden cardiac arrest? A. To slow the heart rate. B. To convert ventricular fibrillation or pulseless ventricular tachycardia to a perfusing rhythm. C. To increase myocardial contractility. D. To improve blood pressure. Answer B. To convert ventricular fibrillation or pulseless ventricular tachycardia to a perfusing rhythm. This question asks about the core reason for early defibrillation. The primary purpose of defibrillation is to deliver an electrical shock to the heart to reset the chaotic electrical activity of ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, allowing the heart's natural pacemaker to resume a normal, organized rhythm. While a successful defibrillation may indirectly improve blood pressure, its direct action is to stop the malignant rhythm, not to increase contractility or slow the heart rate. Remember, defibrillation is the most effective treatment for VF and private. Question 20. When delivering ventilations with a bag mask device during adult CPR, what is the recommended frequency? A. 1 breath every 3 to 4 seconds. B. 1 breath every 5 to 6 seconds. C. 2 breaths every 10 seconds. D. 10 to 12 breaths per minute. Answer B. 1 breath every 5 to 6 seconds. This question focuses on the appropriate ventilation rate during adult CPR when an advanced airway is not in place. For adult CPR with a bag mask device, without an advanced airway, the recommended ventilation rate is 1 breath every 5 to 6 seconds, delivered after every 30 compressions. This translates to about 10 to 12 breaths per minute. Once an advanced airway is in place, continuous compressions are performed, and ventilations are given at a rate of 1 breath every 6 seconds without interrupting compressions. Ensure you deliver each breath over about 1 second to avoid gastric inflation. Question 21. Which of the following is considered a non-shockable rhythm in the ACLS algorithm? A. Ventricular fibrillation, VF. B. Pulseless electrical activity, PEA. C. Pulseless ventricular tachycardia, private. D. Polymorphic ventricular tachycardia. Answer B. Pulseless electrical activity, PEA. This question tests your ability to differentiate between shockable and non-shockable rhythms in cardiac arrest. Pulseless electrical activity, PEA, is a non-shockable rhythm, meaning defibrillation is not effective for it. Ventricular fibrillation, VF, pulseless ventricular tachycardia, private, and polymorphic ventricular tachycardia are all shockable rhythms for which defibrillation is the primary intervention. For PEA, the focus is on high-quality CPR and identifying and treating reversible causes, the H's and T's. Remember, if there's electrical activity but no pulse, it's PEA, and you don't shock it. Question 22. What is the primary goal of providing continuous chest compressions with minimal interruptions during CPR? A. To prevent gastric inflation. B. To avoid rescuer fatigue. C. To maximize coronary and cerebral perfusion. D. To allow for accurate rhythm analysis. Answer C. To maximize coronary and cerebral perfusion. This question addresses the fundamental principle behind high-quality CPR. The primary goal of continuous chest compressions with minimal interruptions is to maximize blood flow to the heart, coronary perfusion, and brain, cerebral perfusion. Each compression creates a small amount of blood flow, and stopping compressions even for a short period significantly reduces this flow, taking several compressions to rebuild. While avoiding fatigue and allowing for rhythm analysis are considerations, maximizing perfusion is the critical priority for patient survival. Always remember that hands-on time on the chest is crucial for effective CPR. Question 23. A patient develops narrow complex tachycardia with a regular rhythm at 170 BPM. They are awake, alert, and normotensive. Which intervention is most appropriate first? A. Synchronized cardioversion. B. Amiodarone 150 mg for over 10 minutes. C. Vagal maneuvers. D. Adenosine 6 mg rapid 4 push. Answer: C. Vagal maneuvers. This question describes a stable narrow-complex tachycardia. For stable narrow-complex tachycardias, the initial intervention should always be vagal maneuvers, such as carotid sinus massage or the modified Valsalva maneuver. These non-pharmacologic interventions can sometimes convert the rhythm back to normal sinus rhythm by stimulating the vagus nerve. If vagal maneuvers are unsuccessful, then adenosine would be the next step, followed by other medications or cardioversion if instability develops. Always try vagal maneuvers first if the patient is stable. Question 24. What is the recommended post-cardiac arrest blood pressure target to aim for after ROSC is achieved? A. Systolic blood pressure, SBP, less than 90 mm of mercury. B. Mean arterial pressure, MAP, 65 mm of mercury or greater. C. Systolic blood pressure, SBP, greater than 180 mm of mercury. D. Diastolic blood pressure, DBP, less than 60 mm of mercury. Answer: B. Mean arterial pressure, MAP, 65 mm of mercury or greater. This question focuses on post-cardiac arrest care. After return of spontaneous circulation, ROSC, maintaining adequate cerebral and coronary perfusion is vital. The recommended target for blood pressure optimization is a mean arterial pressure, MAP, of 65 mm of mercury or greater, or a systolic blood pressure, SBP, of 90 mm of mercury or greater. This helps ensure vital organ perfusion while avoiding excessive blood pressure, which could increase myocardial oxygen demand. Closely monitor blood pressure and use fluids or vasopressors as needed to maintain this critical target. Question 25. Which of the following is a common reversible cause, H, of cardiac arrest? A. Trauma. B. Toxins. C. Tamponade, cardiac. D. Hypovolemia. Answer: D. Hypovolemia. This question tests your knowledge of the H's and T's, which are the common reversible causes of cardiac arrest. The H's stand for hypovolemia, hypoxia, hydrogen ion, acidosis, hypo-/hyperkalemia, and hypothermia. The T's stand for toxins, tamponade, cardiac, tension pneumothorax, and thrombosis, coronary or pulmonary. Hypovolemia is a very common and treatable cause of pulseless electrical activity, PEA, or asystole. Remembering the H's and T's helps guide your search for underlying causes during resuscitation. Question 26. When should aspirin be administered to a patient experiencing acute coronary syndrome, ACS? A. Only if confirmed myocardial infarction by cardiac enzymes. B. As soon as possible, unless contraindicated. C. After all other medications have been given. D. Only if the patient requests it. Answer: B. As soon as possible, unless contraindicated. This question emphasizes the urgency of aspirin administration in acute coronary syndrome, ACS. Aspirin is a cornerstone of initial management for suspected ACS because it inhibits platelet aggregation, which is crucial in preventing further clot formation in the coronary arteries. It should be administered as soon as possible, ideally by chewing, unless there is a known allergy or active bleeding. Delaying aspirin administration can worsen outcomes. Remember, chew and give aspirin promptly for suspected heart attacks. Question 27. What is the recommended concentration and administration route for naloxone in a patient with suspected opioid overdose causing respiratory depression, who is not in cardiac arrest? A. 1 mg 4/IO. B. 2 mg IM/IN. C. 0.4 mg 4/IM/IN/SQ. D. 10 mg 4/IO. Answer: C. 0.4 mg 4/IM/IN/SQ. This question focuses on managing opioid overdose in a non-arrest setting. For suspected opioid overdose causing respiratory depression, but not full cardiac arrest, naloxone can be administered via intravenous, intramuscular, intranasal, or subcutaneous routes. The typical initial dose is 0.4 mg, titrated to effect improved respiratory effort. Higher doses or more rapid administration may be used in cardiac arrest or severe respiratory depression. While the 2 mg IM/IN dose is often seen in pre-hospital settings for general use, 0.4 mg is a common initial dose across multiple routes in a controlled environment, highlighting the principle of titration. Always prioritize supporting breathing and be ready to repeat doses as needed until respirations improve. Question 28. A patient is in cardiac arrest, and the rhythm is asystole. What is the immediate next step after confirming asystole? A. Deliver an immediate defibrillation. B. Administer 1 mg 4/IO epinephrine. C. Check for a pulse immediately. D. Start transcutaneous pacing. Answer: B. Administer 1 mg 4/IO epinephrine. This question addresses the management of a non-shockable rhythm in cardiac arrest. Asystole, a flat line on the ECG, is a non-shockable rhythm. After confirming asystole, e.g., by checking lead connections, the immediate next step is to continue high-quality CPR and administer 1 mg of epinephrine intravenously or intraosseously. Defibrillation is not effective for asystole, and pacing is not typically recommended in established asystole during cardiac arrest. The focus for asystole is on CPR, epinephrine, and searching for reversible causes. Question 29. A 60-year-old patient presents with acute onset of shortness of breath and an ECG showing new left bundle branch block, LBBB. What should be the initial consideration? A. Stable angina. B. Acute coronary syndrome, ACS, equivalent. C. Pericarditis. D. Atrial fibrillation with rapid ventricular response. Answer: B. Acute coronary syndrome, ACS, equivalent. This question tests your recognition of ECG findings that are considered STEMI equivalents. A new or presumably new left bundle branch block, LBBB, in the setting of acute chest pain or symptoms suspicious for ischemia should be treated as an acute coronary syndrome, ACS, equivalent. This means the patient should be managed similarly to a STEMI, with consideration for urgent reperfusion, such as activation of the cardiac catheterization lab. It's crucial not to dismiss new LBBB in symptomatic patients, as it can mask STEMI. Always consider new LBBB in the context of symptoms as a sign of potential acute myocardial infarction. Question 30. What is the most critical time-dependent intervention for a patient experiencing a stroke due to an ischemic clot? A. Aspirin administration. B. Permissive hypertension. C. Administration of fibrinolytic therapy, e.g., alteplase. D. Long-term rehabilitation planning. Answer: C. Administration of fibrinolytic therapy, e.g., alteplase. This question focuses on acute stroke management. For an ischemic stroke, caused by a clot, the most time-critical intervention is the administration of fibrinolytic therapy, such as alteplase, TPA. This medication can dissolve the clot and restore blood flow to the brain, but it must be given within a narrow time window, typically 3 to 4.5 hours from symptom onset, to be effective and safe. Delaying this treatment can lead to worse neurological outcomes. While other interventions like aspirin or permissive hypertension are part of stroke care, they are not as time-dependent as fibrinolytics for clot dissolution. Time is brain in stroke, emphasizing the urgency of rapid assessment and treatment. Question 31. What is the recommended post-cardiac arrest target for oxygen saturation, SpO2? A. Less than 90%. B. 92 to 98%. C. 98 to 100%. D. Greater than 99%. Answer: B. 92 to 98%. This question addresses appropriate oxygenation goals after return of spontaneous circulation, ROSC. Following ROSC, it is important to optimize oxygenation to prevent secondary brain injury, but hyperoxia, too much oxygen, can also be harmful. The recommended target for SpO2 is generally 92 to 98%. Titrate oxygen delivery to achieve this range, avoiding both hypoxemia and hyperoxemia. This balanced approach helps protect vital organs, especially the brain, from oxygen-related damage. Question 32. A patient with a history of heart failure presents with increasing shortness of breath, bilateral crackles, and a blood pressure of 160/90 mmHg. What is the most appropriate initial medication? A. Adenosine. B. Dopamine. C. Nitroglycerin. D. Epinephrine. Answer: C. Nitroglycerin. This question describes a patient in acute decompensated heart failure with signs of pulmonary edema, shortness of breath, crackles, and hypertension. Nitroglycerin is an excellent initial medication in this scenario because it acts as a venodilator, reducing preload, blood returning to the heart, which helps to alleviate pulmonary congestion. It also has arterial vasodilatory effects, which can help reduce afterload and lower blood pressure. Adenosine is for SVT, dopamine/epinephrine are vasopressors for hypotension, which is the opposite of what's needed here. Remember, nitroglycerin is often the first choice for flash pulmonary edema with elevated blood pressure. Question 33. What is the primary method for confirming proper endotracheal tube, ETT, placement in an adult during cardiac arrest? A. Auscultation of bilateral breath sounds. B. Observing chest rise with ventilations. C. Continuous waveform capnography. D. Esophageal detector device. Answer: C. Continuous waveform capnography. This question highlights the gold standard for confirming endotracheal tube placement. While auscultation and chest rise are important initial indicators, continuous waveform capnography is the most reliable method for confirming proper ETT placement in an adult during cardiac arrest. It provides real-time feedback on CO2 exhalation, confirming that the tube is in the trachea and not the esophagus. If there is no waveform, the tube is likely misplaced. Always rely on capnography for definitive ETT confirmation. Question 34. What is the significance of the pit crew approach in resuscitation? A. It assigns one person to manage all medications. B. It emphasizes clear roles and simultaneous performance of tasks. C. It prioritizes family presence during resuscitation. D. It focuses on minimizing equipment use during CPR. Answer, B. It emphasizes clear roles and simultaneous performance of tasks. This question refers to a critical concept in team dynamics during resuscitation. The pit crew approach emphasizes the importance of assigning specific roles to team members and performing tasks simultaneously to minimize interruptions in high-quality CPR. Much like a race car pit crew, each member has a defined role, e.g., compressor, ventilations, medications, defibrillator, allowing the team to work efficiently and seamlessly. This approach significantly improves the quality of CPR and patient outcomes. Implementing clear roles is a cornerstone of effective resuscitation team performance. Question 35. A patient is stable with a heart rate of 50 bpm and PR intervals that progressively lengthen until a QRS complex is dropped. What is this rhythm? A. First-degree AV block. B. Second-degree AV block type 1, Wenckebach. C. Second-degree AV block type 2. D. Third-degree AV block, complete heart block. Answer, B. Second-degree AV block type 1, Wenckebach. This question describes the classic characteristics of a specific type of heart block. Second-degree AV block type 1, also known as Wenckebach, is identified by a progressive lengthening of the PR interval until a QRS complex is dropped, followed by a reset. This pattern is often cyclical. First-degree AV block has a consistently prolonged PR interval without dropped beats, while type 2 has sudden, unexpected dropped QRS complexes without progressive PR lengthening. Third-degree AV block shows complete dissociation between P waves and QRS complexes. Recognizing these distinct patterns is vital for proper rhythm interpretation. Question 36. What is the initial recommended treatment for a responsive patient experiencing symptomatic bradycardia with signs of poor perfusion? A. Immediate transcutaneous pacing. B. Atropine 0.5 mg 4. C. Dopamine infusion. D. Epinephrine infusion. Answer, B. Atropine 0.5 mg 4. This question addresses the initial drug therapy for unstable bradycardia. For a responsive patient with symptomatic bradycardia causing signs of poor perfusion, e.g., hypotension, altered mental status, the first-line medication is atropine, given as 0.5 mg 4. If atropine is ineffective, then transcutaneous pacing, dopamine, or epinephrine infusions would be considered. It's crucial to try atropine first before moving to more invasive or complex treatments like pacing or vasopressors. Question 37. What is the goal oxygen saturation for a patient with acute coronary syndrome, ACS, without hypoxemia? A. 90 to 94%. B. 94 to 98%. C. Greater than 90%. D. 100%. Answer, C. Greater than 90%. This question addresses oxygen administration in acute coronary syndrome. For patients with suspected acute coronary syndrome, ACS, without hypoxemia, SpO2 less than 90%, supplemental oxygen is only indicated if their oxygen saturation is less than 90%, if they are experiencing signs of heart failure, or if they are short of breath. The goal is to maintain oxygen saturation greater than 90%. Routine oxygen administration to all ACS patients is no longer recommended if their SpO2 is already above 90%, as it can lead to hyperoxia, which may be harmful. Administering oxygen is important, but only when truly needed, so avoid giving it if the patient is already well oxygenated. Question 38. A patient is being evaluated for a possible ischemic stroke. Which of the following is the most important piece of information to obtain quickly? A. Last known normal, LKN, time. B. Detailed social history. C. Family history of stroke. D. Baseline blood glucose. Answer A. Last known normal, LKN, time. This question emphasizes a critical factor in acute stroke assessment. The last known normal, LKN, time is absolutely crucial for determining eligibility for time-dependent reperfusion therapies, such as intravenous fibrinolytic therapy, alteplase, or mechanical thrombectomy. These treatments have strict time windows from symptom onset. While other information is important, the LKN time directly impacts treatment decisions and urgency. Always prioritize establishing this time accurately when evaluating a stroke patient. Question 39. During a resuscitation, the team leader asks for feedback on chest compression quality. Which of the following indicates high-quality compressions? A. Compression depth of 1.5 inches, 3.8 centimeters. B. Compression rate of 90 per minute. C. Full chest recoil after each compression. D. Visible chest rise with each compression. Answer C. Full chest recoil after each compression. This question tests your knowledge of high-quality CPR components. Full chest recoil after each compression is crucial for allowing the heart to refill with blood between compressions, maximizing blood flow during the next compression. Inadequate recoil reduces coronary and cerebral perfusion. A depth of 1.5 inches is too shallow, a rate of 90 per minute is too slow, and visible chest rise is associated with ventilations, not compressions. Always ensure you are allowing the chest to fully recoil between compressions. Question 40. What is the appropriate initial action for a patient presenting with an unwitnessed collapse and a monitor showing asystole? A. Defibrillate immediately. B. Start chest compressions. C. Administer atropine. D. Attempt synchronized cardioversion. Answer B. Start chest compressions. This question addresses the immediate response to a patient found in unwitnessed cardiac arrest with asystole. In any pulseless patient, regardless of the initial rhythm, the first and most critical action is to immediately start high-quality chest compressions. The ACLS algorithm prioritizes pushing hard, pushing fast, and minimizing interruptions. Defibrillation is not effective for asystole, and medications like atropine come after the initiation of CPR. Always begin with compressions. Question 41. What is the recommended dose of intravenous magnesium sulfate for torsades de pointes with a pulse? A. 1 gram 4/5 to 10 minutes. B. 2 grams 4/5 to 10 minutes. C. 6 milligrams for rapid push. D. 150 milligrams for over 10 minutes. Answer B. 2 grams for over 5 to 10 minutes. This question tests your knowledge of specific drug treatments for unique arrhythmias. For torsades de pointes, a polymorphic ventricular tachycardia often associated with a prolonged QT interval, the first-line treatment is intravenous magnesium sulfate. The recommended dose is 1 to 2 grams typically given over 5 to 10 minutes if the patient has a pulse. If the patient is pulseless with torsades, the same dose is given more rapidly. Adenosine and amiodarone are for different types of tachyarrhythmias. Remember that magnesium is the specific treatment for torsades de pointes. Question 42. A patient with suspected acute coronary syndrome complains of severe chest pain and is given aspirin, nitroglycerin, and morphine. Their vital signs are stable. What additional medication should be considered if not already given? A. Furosemide. B. Clopidogrel, or other P2Y12 inhibitor. C. Digoxin. D. Metoprolol, beta blocker. Answer: D. Metoprolol, beta blocker. This question relates to the standard initial pharmacotherapy for acute coronary syndrome. In the absence of contraindications, oral beta blockers like metoprolol should be administered early to patients with suspected ACS, especially those with ongoing ischemic pain, tachycardia, or hypertension. Beta blockers reduce myocardial oxygen demand by slowing heart rate and decreasing contractility, helping to limit infarct size and improve outcomes. Clopidogrel is often given but typically after ECG confirmation and in consultation with cardiology, while furosemide and digoxin are not primary ACS medications. Always consider beta blockade early in ACS if there are no contraindications. Question 43. A patient is in cardiac arrest, and the monitor shows a rhythm compatible with ventricular fibrillation. After the first shock, the rhythm persists. What is the next most appropriate action during the subsequent 2-minute CPR cycle? A. Administer atropine 1 mg 4/IO. B. Administer epinephrine 1 mg 4/IO. C. Administer adenosine 6 mg 4-push. D. Administer sodium bicarbonate. Answer: B. Administer epinephrine 1 mg 4/IO. This question again tests the cardiac arrest algorithm for shockable rhythms. Following the first shock for ventricular fibrillation, VF, and 2 minutes of CPR, if the rhythm persists, the next step is to deliver a second shock, followed immediately by another 2 minutes of CPR. During this second 2-minute CPR cycle, epinephrine 1 mg 4/IO should be administered. Epinephrine helps improve coronary and cerebral perfusion and is given every 3 to 5 minutes during cardiac arrest. Atropine is for bradycardia, adenosine for SVT, and sodium bicarbonate is not routinely used in cardiac arrest. Remember to give epinephrine during the CPR cycle after the second shock. Question 44. What is the primary purpose of identifying and treating reversible causes, H's and T's, during cardiac arrest? A. To determine if the patient is eligible for a transplant. B. To improve the chances of achieving return of spontaneous circulation, ROSC. C. To decide on the appropriate long-term care facility. D. To prevent future cardiac events. Answer: B. To improve the chances of achieving return of spontaneous circulation, ROSC. This question focuses on the rationale behind searching for H's and T's in cardiac arrest. Identifying and treating reversible causes is crucial because addressing these underlying issues, like hypovolemia, hypoxia, tension pneumothorax, can directly lead to the achievement of return of spontaneous circulation, ROSC. If the root cause of the arrest is not fixed, even perfect CPR and medications may not be enough. While prevention is a long-term goal, the immediate purpose during arrest is to get the heart beating effectively again. Always integrate searching for and treating reversible causes into your resuscitation efforts. Question 45. Which of the following is a potential complication of excessive ventilation during cardiac arrest? A. Increased venous return. B. Increased coronary perfusion pressure. C. Gastric inflation and aspiration. D. Improved cerebral oxygenation. Answer: C. Gastric inflation and aspiration. This question addresses the dangers of hyperventilation during CPR. Providing excessive ventilations, too many breaths or breaths that are too forceful/long, during cardiac arrest can lead to gastric inflation, increasing the risk of regurgitation and aspiration. It can also impede venous return to the heart by increasing intrathoracic pressure, thereby decreasing cardiac output and cerebral and coronary perfusion pressure. Optimal ventilation involves delivering just enough volume to see chest rise over 1 second at the correct rate. Remember, less is more when it comes to ventilations during CPR. Question 46. What is the appropriate initial response for a patient presenting with suspected stable monomorphic ventricular tachycardia with a pulse? A. Immediate synchronized cardioversion. B. Amiodarone 150 mg for over 10 minutes. C. Adenosine 6 mg rapid 4 push. D. Immediate transcutaneous pacing. Answer: B. Amiodarone 150 mg for over 10 minutes. This question asks about the initial management of stable monomorphic ventricular tachycardia. For stable monomorphic VT, the first-line treatment is antiarrhythmic medication, with amiodarone 150 mg for over 10 minutes, being a common choice. Procainamide and sotalol are also options. Synchronized cardioversion is reserved for unstable tachycardias. Adenosine is typically for narrow complex tachycardias or for diagnostic purposes in wide complex rhythms, while pacing is for bradycardia. If a patient has a wide complex tachycardia but is stable, try antiarrhythmics first. Question 47. What is the recommended dose of intravenous fluid bolus for a hypotensive patient in septic shock? A. 500 milliliters. B. 1 liter. C. 30 milliliters per kilogram. D. 50 milliliters per kilogram. Answer: C. 30 milliliters per kilogram. This question tests your knowledge of fluid resuscitation in shock. For a hypotensive patient with suspected septic shock, the initial fluid resuscitation recommendation is a rapid intravenous bolus of 30 milliliters per kilogram of crystalloid. This bolus helps to improve intravascular volume and blood pressure. Ongoing fluid administration should be guided by reassessment of the patient's hemodynamic status and response. While some situations might call for smaller or larger boluses, 30 milliliters per kilogram is the standard initial fluid challenge for septic shock. Question 48. A patient is found unresponsive and pulseless. The AED delivers a "no shock advised" message. What is the next immediate action? A. Check for a pulse for 10 seconds. B. Begin CPR, starting with chest compressions. C. Deliver 2 rescue breaths. D. Reanalyze the rhythm. Answer: B. Begin CPR, starting with chest compressions. This question describes a critical step in the chain of survival when an AED provides a "no shock advised" message for an unresponsive, pulseless patient. If the AED indicates "no shock advised," it means the rhythm is either asystole or PA, neither of which are shockable. In this scenario, the immediate next action is to resume high-quality CPR, starting with chest compressions, for 2 minutes. There's no need to recheck the pulse unless signs of ROSC appear. Always follow AED instructions and prioritize chest compressions if no shock is advised. Question 49. What is the primary role of the team leader during a resuscitation attempt? A. Performing chest compressions. B. Administering all medications. C. Providing continuous rhythm analysis. D. Overseeing the resuscitation efforts and making critical decisions. Answer: D. Overseeing the resuscitation efforts and making critical decisions. This question defines a key role in effective team dynamics during resuscitation. The primary role of the team leader is to oversee the entire resuscitation effort, ensure high-quality CPR, make critical decisions, delegate tasks, and provide clear communication. While team leaders should be capable of performing any task, their main function is to guide the team and manage the overall process, not to perform all hands-on tasks themselves. An effective leader guides the team to success, ensuring all components of the algorithm are met efficiently. Question 50. A patient experiences sudden cardiac arrest. The monitor shows coarse ventricular fibrillation. What is the most important immediate action? A. Administer intravenous amiodarone. B. Perform synchronized cardioversion. C. Deliver immediate defibrillation. D. Obtain an arterial blood gas. Answer: C. Deliver immediate defibrillation. This question emphasizes the urgency of defibrillation for shockable rhythms. Coarse ventricular fibrillation, VF, is a shockable rhythm, and immediate defibrillation is the single most important intervention to improve survival in cardiac arrest due to VF. Every minute of delay in defibrillation reduces the chance of survival significantly. While CPR is ongoing, the priority is to get the defibrillator ready and deliver the shock as quickly as possible. Amiodarone and arterial blood gases come later in the algorithm, and synchronized cardioversion is for tachycardias with a pulse. For VF, shock them is the immediate and crucial action.